Hello everyone, welcome to today's live broadcast, Prostate Cancer Screening Update 2016. I am Christina Mahalik of LabRoots, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. We have a few important announcements before we begin. This broadcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button on the lower left of the presentation window. We'll try to answer as many questions as we can. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you have any technical problems viewing or hearing this presentation, please click on the support button at the top right of your presentation window, or submit your problem through the green Q&A button located in your lower left corner. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the CE button located at the bottom left-hand corner of your webpage and follow the process of obtaining your credits. I would now like to introduce today's speaker, Dr. Judd Moul. Dr. Judd Moul is James H. Siemens, MD, Professor of Surgery, Division of Urologic Surgery, and Director of the Duke Prostate Center, Duke Cancer Institute at Drake University Medical Center. In 2004, he completed a 26-year U.S. Army career, retiring as a full colonel in the Medical Corps, and became chief of the Division of Urologic Surgery at Duke, serving as chief from 2004 to 2011. He started the Duke Prostate Center and is now a full-time member of the Duke Cancer Institute and sees many men with elevated PSA in all stages of prostate cancer. Dr. Moul is widely published in the field and is a noted international authority on prostate cancer screening and treatment. I will now turn it over to Dr. Moul for his presentation. Thank you, Doctor.
Thank you very much. It's really a pleasure and honor to be here. I'm going to today talk about prostate cancer screening, and we're going to provide an update for 2016. As many of you listening in today are probably aware, prostate screening has gotten to be extremely controversial over the last couple years, and we'll go into some of this controversy and then hopefully have some time for question and answer about some of the common scenarios you may face in your practice when you're having a patient in front of you who has an elevated PSA or is trying to decide if they would like to be screened for prostate cancer. When we talk about screening for any disease, whether it be prostate cancer, breast cancer, or even a non-malignant condition, the goals of any screening program are listed on this slide. The disease should be a life-threatening disease. You should use an accurate screening test. The test should have high sensitivity. Sensitivity meaning that the test is positive if the patient actually has the disease. The test should also have high specificity, meaning that if the patient does not have the disease, the test should be negative. The costs of the detection of the disease must be acceptable. There should be effective treatment available for the disease. In other words, why screen for something if you cannot treat it? The treatment must have acceptable morbidity. In other words, the treatment must be acceptable to patients. So you're not causing more harm than good. And then, most importantly, this entire program should improve survival. And to have an ideal screening test for any disease or condition, they should meet all these criteria. So what's been going on? Well, in 2012, and then it was published in 2013, the U.S. Preventative Services Task Force, and you see on this slide That's abbreviated as USPSTF. Basically, the task force found that PSA testing did not really result in a benefit. And so they came to the conclusion that PSA testing was essentially no good and gave it a D rating, which basically means that they felt that there was more harm than good in the PSA test. Now, how in the world did they come to that? The PSA test had been used since the late 1980s or early 1990s and has been a widespread screening test for prostate cancer. And then all of a sudden, in 2012, 2013, this guideline group that's part of the, or at least authorized by the federal government, came out saying the PSA test should not be used. Well, before we talk about the pros and cons, what has happened since 2012 is that we've seen primary care physicians, take the U.S. Preventative Services Task Force to heart, and they have basically stopped screening for prostate cancer. And as a result of that, what we're starting to see now is rates of more advanced prostate cancer go up. In other words, when you stop screening for a condition, the condition itself doesn't go away, but the stage of diagnosis goes up. You're catching the cancer later. And we're starting to see evidence of that in light of the backlash against screening and not using the PSA test. But other experts say we've thrown the baby out with the bathwater, meaning we've stopped screening for prostate cancer using the PSA test, and was that a hasty decision? Was that decision made rationally? Was that decision made on the best evidence? And now, looking back after a couple of years, there are many experts who believe that we did throw the baby out with the bathwater and that the U.S. Preventative Services Task Force may have overreacted in giving the PSA test a D rating. Let's look at some of the prostate cancer screening trials that have been conducted. And there's evidence going back as early as 2004 from a study from Scandinavia. Then there was a Quebec study from Canada in 2004 and another small study from Stockholm in 2009 that provided some evidence, but not really good evidence on the benefits or harms of screening. But highlighted on this slide are the PLCO trial and the European randomized study for prostate cancer screening. Both of these key studies, randomized trials, were published in 2009 in the New England Journal of Medicine, and both of these trials formed the basis for why the U.S. Preventative Services Task Force gave the PSA test a D rating. So those two studies in 2009, those two randomized trials, were what drove the guidelines from the U.S. Preventative Services Task Force. So let's take a look at these two major clinical trials of prostate cancer screening, and the trials gave conflicting results. First, the U.S. study, which was called the, again, PLCO, the conclusions published in the New England Journal of Medicine were that after 7 to 10 years of follow-up, the rate of deaths from prostate cancer was very low and did not differ significantly between the two study groups. Two study groups were a group that was randomized to be getting the PSA test and a group that was randomized to routine care, which mean they did not have the PSA test as part of this defined clinical trial. Now, the other study, the European study, which you see down in the second part of this slide, showed PSA-based screening reduced the rate of death from prostate cancer by 20%, but was associated with a high risk of overdiagnosis. So in other words, we have one clinical trial saying that PSA testing did not result in a declining death rate from prostate cancer That was the American study, but yet the European study said that screening reduced the death rate from prostate cancer by 20%, but they talk about overdiagnosis. In other words, there were a lot of men that they diagnosed with very early stage prostate cancer, and many of these were elderly men, and they said in effect that they opened up a can of worms in a certain group of older men and picked up cancers that should have never been detected. So they did find a benefit, but they also found some over-detection. Now, these trials were designed differently. First off, the American trial, the PLCO trial, was conducted in the United States. The European trial was conducted in Europe. And the PLCO trial found no mortality benefit in favor of PSA testing. The European study found a 20% mortality in favor of PSA testing. The PLCO trial enrolled 76,000 men. The European trial enrolled 182,000 men. The PLCO used a PSA threshold of 4.0, and the European trial used a PSA threshold of 3.0. In other words, what does this mean? What does a PSA threshold mean? That meant in the clinical trial, if a participant had a PSA level above 4 or above 3, that would have been the trigger to make the referral to urologist, who would have then recommended a prostate biopsy. Now, 50% of the subjects in the American trial actually received a biopsy. In other words, only 50% of the patients who had a PSA threshold above 4 actually received a prostate biopsy. On the other hand, in the European trial, 85% of men who had an abnormal PSA were biopsied. So that's a big difference. And then the biggest problem with the American trial, the biggest problem with the PLCO trial, if you don't really remember anything else about this talk today, the key teaching point is that 52%, or more than half, of the men enrolled in the control group actually had a PSA test. And you say, well, how can that be? These were men who were randomized to no screening. Well, PSA was already common in the United States at that time, and so more than half of the men who were enrolled in this trial in the control group got a PSA on the sly with their primary care physician. And so in the European trial, at the time the study was done, there was very little PSA testing done in Europe. So there was less opportunity for patients to get a sneaky PSA done outside the confines of the trial, and so the PSA contamination rate was only 20%. And so that's really the two clinical trials that resulted in this D rating from the U.S. Preventative Services Task Force. The major criticism of the PLCO, the major criticism, this was the American trial, was that PSA was tested frequently in the control group. As I said earlier, there was a high contamination rate. 40% of the men who were randomized to the control group, where they were not supposed to get PSA testing, 40% outside the trial went to another doctor and had a PSA test during that first year. 52% by year 6. And so one can understand how contaminated the control group is. If you're trying to test whether PSA testing makes a difference, you would have needed a control group that would have had much less PSA testing. And so that many people feel that the PLCO trial is so flawed that it should not have even been used in the deliberations of the U.S. Preventative Services Task Force. But in summary, these 5 screening trials, I mean, we talked earlier briefly about the trial in Scandinavia, the Quebec trial, the Stockholm trial. These were smaller studies And 2 of the 3 earlier studies did not show a major benefit to screening, but the Quebec trial did show reduced mortality in the group of men who were assigned to PSA testing. Then the 2 major trials, PLCO, showed no benefit, but high PSA contamination rate, and the European trial showed a 20% improvement in prostate cancer mortality in men who were screened, but also there were some differences country to country in how the study was actually conducted. So this is a summary of the screening trials. Then Cochrane did a systematic review of the screening studies, and that was done in 2013. And what did we learn from the Cochrane systematic review? Well, screening was associated with an increased diagnosis of prostate cancer. Again, if you introduce any screening test to a population, in this case PSA, the men who got the PSA test had a higher rate of cancer detection than the men who were randomized to no testing. That makes sense. Also, screening was associated with more localized disease, meaning if you screened for prostate cancer, you found more cases of disease that was confined to the prostate and less advanced prostate cancer. But according to Cochrane, pooled data from all 5 of the randomized trials, 341,000 participants, showed no reduction in cancer-specific mortality. Now again, you could argue that garbage in, garbage out, because the Cochrane review did include the PLCO American trial, and since the American trial had such tremendous contamination in the control group, one could have argued that it was inappropriate for Cochrane to include this trial in the systemic review, but nevertheless it was included. And as a result, this systematic review suggests no survival benefit to PSA testing. Again, no reduction in all-cause or prostate cancer-specific mortality. But as we said, there are criticisms of this systematic review, that the risk of biases was assigned each study under consideration. However, they did not account for the differing rates of PSA contamination. And again, as I said earlier, more than half of the patients in the PLCO did have PSA contamination. More than half of those men in the control group who were randomized to no PSA testing had gotten a PSA test outside the confines of the trial. And then differing rates of biopsy for screen positive subjects. So this is where we are, or where we were. If we look at the most recent update of the European randomized study for prostate cancer screening, there is now reported a 27% reduction in prostate cancer specific mortality at 13-year follow-up for the men who did get a PSA test. So in long-term follow-up, this large European trial shows a significant benefit in favor of PSA testing compared to men who were not screened. And that's illustrated on the left side of this PowerPoint slide. Now, another study that was not included in the studies that the U.S. Preventative Services Task Force is called the Göteborg study. This is a study from Scandinavia where younger men between 55 and 69 were randomized to screening versus no screening. We haven't talked about the Göteborg study until now in the talk. And this particular latest study, again, was not included in the U.S. Preventative Services Task Force deliberations in 2012 and 2013, but this can inform us quite a bit because these were younger patients, and the follow-up on this trial was reported out at 14 years of follow-up. So with long follow-up and screening a younger group of men with PSA, they found a 44% reduction in prostate cancer-specific mortality at 14 years of follow-up. So not only do we have the European randomized study for prostate cancer screening showing a 27% reduction in deaths from prostate cancer in men who were screened at 13 years, but the Göteborg study shows a 44% reduction at 14 years. And the NND that you see on this slide, that means number needed to diagnose with prostate cancer to save one life. In the European study, you needed to diagnose 27 prostate cancers in 27 men in order to prevent one prostate cancer death at 13 years of follow-up. In the Göteborg trial, number needed to diagnose was 12. In other words, you needed to diagnose 12 men with prostate cancer to alleviate one death from prostate cancer 14 years later. And those numbers are very comparable to what we see in other diseases where screening is accepted. Those numbers are very similar to, for example, mammography screening for breast cancer or colonoscopy for colorectal cancer. So the key teaching point is that there are 2 randomized trials that show a benefit to PSA testing, and the benefit is comparable to screening efforts in other diseases where we accept that screening test as useful. Now, what are the harms associated with prostate cancer screening? Well, you certainly have some harm associated with prostate biopsy. There's some pain associated with a biopsy of the prostate. There's some risk of blood in the semen, some risk of hematuria, some risk of blood in the bowel movements for a period of time after the biopsy, and some small risk of infection requiring hospitalization after a prostate biopsy. But the biggest risk specifically related to prostate cancer is overdiagnosis. And many people believe that the U.S. Preventative Services Task Force gave the PSA test a D rating, not so much on the PSA test itself, but the downstream consequences of screening. In other words, the task force was not able to necessarily differentiate or separate the PSA test itself from the downstream results. And they said basically that, hey, prostate cancer screening is not that valuable. All you're going to do is overdiagnose a bunch of small, unimportant prostate cancers in elderly men and open up a Pandora's box by overdiagnosing all these men. And that's the main beef that people have had with prostate cancer screening. What was not taken into account in 2012 and 2013 when the U.S. Preventative Services Task Force met was the use of active surveillance. And what's happened between 2012 and now is that we are combating this overdiagnosis by recognizing that a lot of these older men with low volume prostate cancer can be placed on active surveillance. So we're not treating all these men at this point. Overdiagnosis is still a possibility, but we're trying to combat that with not being aggressively treating many of these men with low stage prostate cancer, especially if they're older. So with improved risk stratification, overdiagnosis does not necessarily lead to overtreatment. As I mentioned, over the last 4 years, clinicians who take care of men with prostate cancer are much more likely to do proper risk assessment of those men who are diagnosed, and much more commonly applying active surveillance or close monitoring. We're not necessarily treating all of these men with surgery or radiotherapy. We're treating a lot of these men with a watch and wait scenario, so that we're trying to combat the overdiagnosis and not overtreat many of these men. What I want to do in the next group of slides is talk a little bit about guidelines. And I'm a urologist and a member of the American Urologic Association, so I'd like to spend a few slides talking about the American Urologic Association prostate cancer guidelines. Now, these are not the end-all guidelines. They're, as I'll show in a few minutes, there are quite a few organizations that have prostate cancer guidelines, and we'll compare and contrast those later. But right now, let's spend the next couple of slides. What does the American Urologic Association say about PSA testing? Well, the Urology Association guidelines broke it down into 4 age groups: men less than 40, men age 40 to 54, men age 55 to 69, and men 70 years of age or older. Because prostate cancer is such a generally a slow-growing cancer, and since we're trying to combat overdiagnosis and overtreatment in elderly men, we thought it made sense to try to stratify or think about men in these 4 age groups in reference to how we would screen them for prostate cancer. So first off, if you have a patient in your practice who's less than 40 years of age, even if that gentleman does have a family history, for example, of prostate cancer, the guidelines generally recommend against PSA-based screening for men under age 40. Reason being is that there's such a low incidence and prevalence of prostate cancer in very young men that it really just does not make sense to recommend PSA testing in men in your practice who are less than age 40. And I think that's fairly clear. In the 40 to 54 year age group, screening as a routine is not recommended in men between ages 40 and 54 who are at average risk of prostate cancer. Now, what does average risk mean? Well, let's look at it a different way. What does high risk mean? So we know that African American men, men who self-describe as Black or African American men, and men who report a family history of prostate cancer are at higher risk. What this is saying that if a man is not African American, and if a man does not have a family history of prostate cancer, he would be at average risk, and perhaps we wouldn't automatically offer him periodic PSA screening between ages 40 and 54. Now, I'm going to talk a little bit later about using a baseline PSA to better assess the risk of these men between 40 and 54. But we'll hold that thought for now, about baseline PSA. But in general, the AUA guidelines do not generally recommend routine, periodic, yearly or every other year PSA testing for men 40 to 54. The reason being is the randomized trials that we discussed earlier did not include men under age 55 in those randomized trials. So there's no level 1 evidence from the clinical trials that I've already talked about men 40 to 54. There's just no randomized data to know if screening is beneficial. We know the probability of dying from prostate cancer by or before age 55 is extremely low by SEER data. We know that there's an extremely low number of deaths that could be prevented in screening men in this young age group. And so again, in general, for an average risk man at age 40 to 54, the AUA guidelines do not call for routine PSA screening. Now, the group where there's the strongest evidence for testing is in the age group 55 to 69. And the AUA panel recommends a shared decision-making for men aged 55 to 69, considering PSA testing and proceeding based on the patient's values and preferences. In plain English, they say that we should explain the pros and cons, but in general, if you're going to do PSA testing, this age group between 55 and 69 makes the most sense of testing. You're going to have the largest benefit for screening in this group in all likelihood. And this is the group of men age 55 and 69 that were studied in the Gothenburg clinical trial that I referred to earlier, where there's the strongest benefit in favor of screening. So this is where the AUA really thinks we should put our efforts. Again, shared decision, we should still explain the pros and cons of PSA testing, even for men in this age group. And so in other words, you shouldn't just automatically do the PSA test, just in meaning ordering this blood test without explaining the pros and cons. But once you've explained the pros and cons and the patient wants to move forward with testing, this is the age group, 55 to 69, where it makes most sense. And the screening interval in this group of men is every 2 years. In other words, the AUA guidelines would say that the group where the strongest data is for screening is men in your practice at age 55. You get a PSA at 55, and then you would test them every 2 years through age 69. And intervene or do a biopsy if they have an abnormal PSA during that interval, but at least as far as which group to focus on, it was 55 to 69 and doing testing every 2 years. Now, let's move on to the last group of patients, and that's men in your practice who are age 70 and above. And the AUA guidelines recommends against routine PSA screening in men age 70 plus, or in any patient with less than a 10 to 15 year life expectancy. Reason being that prostate cancer is generally a slow-growing cancer, and therefore you really do not want to open up a Pandora's box on screening an older man where they're not likely to live long enough to see a benefit for diagnosis and treatment of that prostate cancer. Now, on the other hand, we have to individualize. There's some men over age 70 who are in excellent health, who may, in fact, benefit from prostate cancer screening. And again, that's up to us as clinicians to make that individual judgment. But in general, many men above 70 who, especially the ones who are not enjoying excellent health, who have other health conditions, certainly things that might take their life in the next 10 to 15 years, we really don't have any business ordering a PSA test in those men because they're not likely to benefit. Again, beyond age 70, there's really no evidence for screening benefit from the European trial, and certainly overdiagnosis increases with age. So I think the worst thing we could do is, take an elderly man in his mid-70s who has a bunch of other health conditions, diagnose a low-grade prostate cancer, and then that sets in motion a series of events where he might end up getting overtreated for that low-grade, low-stage prostate cancer. Now, let's say you do have a man in your practice who is above 70 who does get a PSA test. The AUA guidelines also say that maybe we can be a little more liberal on what PSA thresholds we would use to recommend a prostate biopsy. And as an example here, they say that perhaps in many men in their 70s, you could probably monitor that patient until the PSA, for example, goes as high as 10 before you would consider a prostate biopsy, especially in the setting of an older man who has BPH, who has an enlarged prostate gland, where much of that PSA is elevated not due to prostate cancer, but just due to the prostate enlargement. There's been quite a bit of data out there also on looking at PSA levels in men in their early 70s. And several studies have said, look, if you have a guy at age 70 who has a PSA that's 3 or less, or 3.5 or less, that given his life expectancy, if he gets to 70 and has a PSA of 3 or 3.5, his chances of developing life-threatening prostate cancer are exceedingly low. So in other words, using that baseline or that threshold of 3 in a 70-year-old man to reassure him, say, look, your PSA is only 3, you're 70 years old, the chance of you developing clinically relevant prostate cancer during your natural lifespan are so low, let's stop testing. Let's just monitor you for other conditions where we can make a difference, but let's put prostate screening off the table now at age 70 because your PSA is low. Now, I mentioned earlier I was going to show a slide of the various organizations' screening guidelines. In yellow on this slide, you see the U.S. Preventative Services Task Force that we talked about at the top of the hour for this program. And remember, the U.S. Preventative Services Task Force does not recommend PSA testing in anybody. So you see that came out in 2012. They don't recommend a baseline PSA. They don't recommend PSA in any group at any age under any conditions. The other organizations have taken various stances. I talked about the AUA guidelines in detail in the different age groups. The AUA primarily recommends PSA testing between 55 and 69 on an every 2-year basis. I'm not going to go through all of these other guidelines, but I did put a red box around baseline PSA, and I said earlier that I was going to come back to that. What does baseline PSA mean? That means that, for example, let's say you have a gentleman in your practice at age 40 or 45. At that age, you are going to do a PSA test. Some people would call that screening, but the other reason you're doing that test is to get a baseline PSA value. The reason that is important is multiple studies have shown now that the baseline PSA at that younger man's age, at 40 or 45, is a very strong predictor of future prostate cancer. In fact, baseline PSA trumps age, family history, and ethnicity as risk factors for prostate cancer. In other words, I said earlier, African American ethnicity or family history, that those are risk factors for prostate cancer, and that's true. But a man at 40 who has a baseline PSA level of greater than 1.5, that 1.5 PSA at 40 is a stronger risk factor for the future development of prostate cancer than his family history or his ethnicity. So that's why you see on this slide the Europeans, the National Comprehensive Cancer Network, and others have recommended that physicians consider getting a baseline PSA at age 40 to 45. NCCN says 45 to 49, but again, the key teaching point is you're getting that one baseline PSA in men in their 40s and using that number to determine their future risk. And if that baseline PSA is less than 1.0, those men are at low risk for prostate cancer over the next 5 years, and you can leave them alone for at least 5 years. If that PSA is, say, for between 1 and 1.5, it's the gray zone. You might want to consider having them getting tested every couple of years. But if that baseline PSA is more than 1.5, that is a risk factor and a red flag for prostate cancer. Those men should be followed at least on a 1 or 2 year basis. And I wouldn't do a biopsy at 1.5, but I would certainly monitor those patients more closely. That group of men is going to be the low-hanging fruit for having the most chance of finding prostate cancer over the next 10 years. Now, at our institution, we've taken a proactive stance with our primary care network. So this slide illustrates the Duke Cancer Institute's PSA screening algorithm for 2016. I'm certainly my goal here is not to go through this in fine detail, but simply to say that our health system has chosen to be proactive. We've rolled out an educational campaign to our Duke University affiliated physicians and our primary care network, and we've chosen to focus this around baseline PSA and ethnicity. We're trying to identify men in the 40s who should be followed more closely, and we're trying to identify high-risk individuals at an age, a younger age, where we can make a difference. And so, again, you'll see more of this, I think, as time goes on, but this is our health system's effort to do a better job of having the urologists work closely with the primary care physicians to do a better job in our younger men and our higher risk men, and in incorporating this baseline PSA risk assessment tool. And in fact, another thing that we did this year, we took a bold move to buck the national guidelines about PSA screening. Most of the guideline organizations would say, oh, don't do any free prostate cancer screenings. That's not any good. Certainly the U.S. Preventative Services Task Force would take us to task for doing this. But we conducted this in the context of shared decision. No patient got a PSA test willy-nilly without counseling on the pros and cons. And the other reason we justified this effort is the fact that 50% of our county, Durham County, North Carolina, is African American. We have a crisis in prostate cancer in eastern North Carolina with a lower socioeconomic African American population that has one of the highest rates of prostate cancer in the world. So we felt it was important to do some focused marketing to try to do a better job of getting these higher risk individuals to our prostate cancer screening, and that took place in September. So we have bucked the trend. We do think there's some value in free prostate cancer screening, as long as it's done in the context of shared decision making, explaining the pros and cons, and also trying to focus on high risk individuals. And again, why did Duke take this bold move on prostate screening? As I said earlier, we have a large African American population. Our university medical practice has something called Project Access. We have a commitment to the entire uninsured population of Durham County, North Carolina. And that's a significant population of African American men, some who have low socioeconomic status, and we need to do a better job of identifying prostate cancer in this high-risk population and potentially trying to treat it earlier when we can make a difference. So that's why we took the bold move on prostate screening. I want to switch gears. We have a little bit of time left and just talk a little bit about new blood markers. We have focused on PSA, and the PSA prostate-specific antigen test has been around again since the late 1980s, early 1990s. It's certainly not going away. It's still forming the basis of the primary screening test for prostate cancer, but there are a number of new blood markers and urine markers that are forming secondary screening tests. In other words, to fine-tune that PSA test before you move directly to a biopsy. And you see this headline, Cochrane markers may improve high-grade prostate cancer detection and reduce unnecessary biopsies. The two blood markers that we're talking about, one is called PHI, and the other one is called the 4K score. These are both blood tests that measure PSA, free PSA, and other molecular components of PSA in the blood, and do a better job than standard PSA in determining either a man's risk for prostate cancer or his risk for harboring higher grade prostate cancer inside his prostate. And I won't spend any more time on these. Suffice it to say that these blood tests are also being incorporated not to replace PSA, but as a complement to PSA in what I call a secondary screen between the initial elevated PSA and the prostate biopsy to try to fine-tune who actually needs a biopsy and who can be followed. A third test you see on the far right-hand side of this slide is called PSA3. That's a molecular urine test, and that's typically done after a prostate massage where you get urine in have the patient give a urine sample, and that is also a useful secondary screen. And it's also the most useful test in a man who's already had a negative prostate biopsy, but where you have a concern where the prostate cancer may have been missed on that first biopsy. So you can use a PSA3 urine test to try to make a better determination if that man needs another biopsy or can simply be followed. Now, after a negative biopsy, again, we just talked about the PSA3 test, where again you can use this urine test after a negative prostate biopsy in a man where you still are concerned about prostate cancer. Another newer test is called Confirm MDX. This is a tissue molecular biomarker done on the prostate biopsy tissue that was negative. It's based on methylation, where if the benign prostate biopsy tissue is methylated, that indicates that you may have cancer inside the prostate close by to where you did the biopsy that you may just have missed. So again, Confirm MDX is a test, molecular test done on a negative prostate biopsy to try to determine if the man may have prostate cancer that was just missed on that biopsy. So the summary and take-home messages from this talk is that prostate cancer screening with PSA certainly remains controversial due to the conflicting results and methodological issues with the randomized controlled trials. And one of my take-home messages is that the American Prostate, Lung, Colorectal, and Ovarian Trial, the PLCO trial that reported no benefit of PSA testing, was really fatally flawed. More than half the patients in that study in the control group also had PSA testing. So many experts now think that that study should not even be considered when taking into account the benefits of PSA testing. Nevertheless, it's still listed in the U.S. Preventative Services Task Force. It still forms a significant reason why the U.S. Preventative Services Task Force gave the PSA test a D rating. Bullet point number 2, the AUA guidelines support PSA testing every 2 years, particularly in men aged 55 and 69 after shared decision. Now, there's also a baseline risk assessment PSA that we talked about that's supported by the NCCN and European guidelines. In other words, if you have a patient in your practice who's in the 40s and you choose to do a PSA test, you can use that baseline first PSA in the 40s as a risk assessment tool. Meaning if those men have a PSA certainly less than 1 or less than 1.5, they're considered lower risk for future prostate cancer. But if that man at 40 or 45 has a baseline PSA more than 1.5, that's a risk factor for prostate cancer, and those men need to be followed more closely, referred to a urologist, or be told that they're at higher risk for prostate cancer. We talked a little bit about some of the novel blood and tissue markers that are entering the field to combat overdetection and overtreatment, and we also talked about active surveillance, where clinicians are not necessarily aggressively treating many of these prostate cancers. We're still diagnosing some low-grade cancers, but we're much more comfortable in following some of these patients without aggressive treatment. Now, I want to just give some audience response type questions and just some key teaching points. Here's a 49-year-old man with poor libido erectile dysfunction, who has a testosterone level of 122. So he's hypogonadal. He has a low testosterone level. Mild bilateral testicular atrophy, and his prostate is small, about 15 grams. But he has a PSA level of 2.4. The next step in this gentleman would be to refer this patient to a urologist in consideration of a prostate biopsy. The key teaching point, he's only 49. He has a PSA that's already 2.4 in the setting of low testosterone. If his testosterone were normal, since PSA is a testosterone-driven gene, his PSA would even be higher. So what we're trying to teach here is that young men should have low PSAs, and that a young man with a low testosterone level with hypogonadism should have a real low PSA, and this 2.4 is a red flag for him, so he should have consideration of at least referral to talk to a urologist about the possibility of a prostate biopsy, or at least close follow-up. What is the optimum PSA screening interval for the average risk man aged 55 to 69 who is in your practice? Is it 1 year, 2 years, 4 years, or 5 years? Well, we discussed this. This was in the AUA guidelines. And in this age group, 55 to 69, the most appropriate interval between PSA tests is going to be 2 years. So the correct answer is B. A 59-year-old white male has been on finasteride for BPH for 2 years and on tamsulosin for 3 years. His current PSA has risen to 3.8. What is the true statement? Well, the key teaching point, the correct answer is D. Finasteride lowers the PSA by 50%. So this gentleman, in reality, even though it says 3.8, he's on finasteride, his PSA is really over 7. And so he's only 59, he has a PSA over 7 corrected on finasteride, and therefore he probably should be seen by a urologist, and urologists would give careful consideration to possibly doing a prostate biopsy because his PSA is significantly higher than it should be at that age and considering the treatment that he's on. So I wanted to be able to go through those, just a couple of audience response questions, and I wanted to warm up the audience for a number of questions. So I think we have just a few minutes left. We're going to, as I've been speaking, a number of questions have come in from our listening audience today, and I'd like to go through those questions now. Certainly if you have other questions, you can certainly let us know. The first question comes in from a listener today.
Thank you for that informative presentation, Dr. Moul. Before we get started on the question and answer session, I would like just to remind our audience how to submit questions. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can. And our first question is, Dr. Moul, it reads, how do I deal with a 40-year-old male who desires to be screened for prostate cancer?
Then get that PSA result, and we would then, use that PSA number. And again, if that PSA was less than 1.5 in that 40-year-old man, we would probably reassure him and maybe let him continue to follow up with his primary care physician. But if the PSA was greater than 1.5, we would probably talk to him about that he's higher risk and want to test him a little bit more often. And I was going to now turn it back over to the moderator to see if there's any other questions that came in the last few minutes.
Thank you so much. Actually, got one question right here. How important is race and family history in determining a man's risk for prostate cancer?
The screen here. So the question is how important is race and family history in determining a man's risk for prostate cancer? They're very important factors. Even though what I talked about earlier was that the baseline PSA, particularly if the baseline PSA for a man in the 40s is above 1.5, that's a strong predictor, but so is ethnicity. We know that African American patients have a high risk of prostate cancer. We know that men with a family history of prostate cancer, particularly men who have more than one family member, particularly a father who was diagnosed with prostate cancer, have a higher risk. So those are all important factors.
Thank you. Another question is, I'm hearing more about MRI of the prostate, and is that getting more accurate? Can you tell me more, please?
I'm hearing more about MRI of the prostate and that it is getting more accurate. Can you tell me more? So, great question. For many years, magnetic resonance imaging was good for certain conditions, but for many years, MRI was felt not to be very accurate for the prostate or for prostate cancer. I think that what's happened now over the last several years is advances have taken place in MRI technology. And so that over the last 3 or 4 years, many major institutions have something called multi-parametric prostate MRI, which is a specialized technique that allows the radiologist better imaging of the inside of the prostate gland. This new multi-parametric MRI is done using specialized equipment at centers of excellence and generally using a larger magnet MRI machine, typically what they call a 3 Tesla MRI magnet. And what we do is we use this MRI and that gives us better images. Now, currently in the United States, the MRI is not always covered by insurance plans in the initial setting, meaning if a patient has an elevated PSA, most insurance plans would cover a prostate biopsy and a prostate ultrasound, but most insurance plans would not cover a screening MRI at that juncture. On the other hand, if you have a patient who's already been through a prostate biopsy and already where the biopsy may not have picked up the cancer, but you have a negative biopsy, the patient has a continued concern about prostate cancer, many times they will cover the MRI as a secondary screening test, meaning they'll do it a little bit later after the patient has already had a biopsy. But it's definitely improving, it's coming along, and more centers of excellence around the United States are using prostate MRI to a greater degree in determining who gets a biopsy and even using the MRI to direct the biopsy. Another question has come in, and I'll just read it here. What is the difference between these new tests such as PHI, the 4K score, and PCA3? Do they replace the good old PSA test? Well, the simple answer is no, they do not replace the PSA test. the vast majority of times for an initial screen for a man in your practice is going to be the baseline PSA, getting the basic total or total plus free PSA. And that still remains the gold standard, the workhorse for prostate cancer screening. However, sometimes now, instead of moving directly from an abnormal PSA directly to a prostate biopsy, sometimes the screening algorithm is being fine-tuned by ordering a PHI blood test or a 4K score blood test or a PCA3 urine test. And at least in some individuals, it can help better explain the PSA test if the PSA is elevated due to cancer or prostate enlargement or other causes. It can, these secondary blood or urine tests can fine-tune and potentially prevent overdiagnosis of small unimportant cancers and improve diagnosis of the high-grade important prostate cancers. And I believe that's it. Again, I think that we don't have any more time for any other questions. Again, it's been a fantastic experience being on the program today with you. I hope that everyone listening and watching has gotten something out of this. And again, I really want to thank LabRoots for inviting me to participate in this important conference. Have a good day.
Since there are no more questions and we've run out of time today, I'd like to once again thank Dr. Moul for his presentation. Today's webcast will be available for on-demand viewing through February 28, 2017. You will receive an email from LabRoots alerting you when this webcast is available for replay. Thank you so much. Have a great day and goodbye from LabRoots.